Hey, Melissa.
Hey.
Welcome back.
Yeah.
How was your cruise?
It was nice. Yeah, it was very good to get away. We had one day of bad weather, but it's December, so.
That's right. Yeah. Well, and I'm a little jealous because obviously I think when you're on the cruise, it was like 17 degrees here and we were like freezing to death.
Yeah. It was the day that it was 17 here, it was 90 degrees. We were snorkeling and swimming and everything. So it was fun.
I've never been snorkeling. I heard it's amazing because you can see like the fish and the water is much clearer over there.
Yes. There was 90 feet of visibility where we were.
Goodness.
And so, you can see forever, it feels like.
Yeah. Well, awesome. Well, we are here wrapping up 2022. Which is crazy because, we are literally near New Year's. And so today we're actually going to do a Common Sense Medicine wrap-up.
Yes.
Right? So for those who don't know, Common Sense Medicine, again, the goal of this podcast is to make complex medical things common, which the more we talk, Melissa, I feel like it should all be kind of common sense.
Yeah, definitely. These are topics that we feel like everybody should know. And I even had a patient today when I was explaining how to monitor blood pressure at home and things like that. He was like, it seems like this is something that should just be taught in high school or something. Like, why would you need to even know about your blood pressure? And so, we're trying to just make topics more common for people, things that they don't teach you in high school.
That's right.
But things that you should probably know about health.
Yes. Melissa, why are we spending like 4 months on an STD lecture when we should really spend like maybe a day on that and spend more time on like blood pressure and nutrition and things that maybe if we did, people would better understand what, how food affects them and stop trying to avoid pork all the time. Pork. Just always gets picked up.
Such a bad rap.
Yeah. Okay. So today, we'll be covering essentially the biggest health stories. And then really starting in 2023, we will be covering a lot of topics like diabetes, high blood pressure, and stuff like that. But today, we'll be touching on big stories like continuous glucose monitors and wearables. And so that was a really, really big thing. A bunch of Apple Watches and EKG monitoring and sugar monitoring. What's the evidence? Does it make a difference? Does it help? Does it not help? Do we get too neurotic? So that's one. We will touch base on childhood vaccination. So, obviously the COVID pandemic, the vaccination campaign, that really got kind of hairy and all over the place. But we're starting to see spill over into measles vaccine and polio vaccines and things that truly are really bad for children, kind of creep in. So maybe we'll touch on that. Telemedicine, right? So and that will tie into a lot of things because there's so many things now. People get their ADHD and antidepressants and everything all diagnosed online now without talking to anybody face to face. Guys, you get ads nonstop about, getting erectile dysfunction treatment online and hair loss online and even testosterone treatments all online, and that was a big boom. Is that good? Is that bad? Is that helpful? We'll be talking about physician burnout.
Yes. Trending in 2022.
That's right. And we don't need to be canceled. Disclaimer. Right. Because, I think you told me we lost a good chunk of our physician workforce during the pandemic.
Almost 10% of physicians. And that statistic only mentioned physicians, but we know that nurses and other support staff and everybody has also been affected.
Yeah. So how do we combat that? And what maybe is the root of all that? And then right, how do we combat that? And then we'll talk about Ozempic or ADHD, but medication shortage, because that was like blood pressure medicines for a while was all over the place. ADHD medication is still under nonstop shortage. Ozempic is on shortage. These medications, is there any way we can treat those without you know, all these things? Or what can we do?
Yeah. Or just knowing that if you can't get your medicine, maybe there's other things that you can be doing in the meantime. Don't throw things at the pharmacist.
Lord
We have heard horror stories.
Yeah.
Because people are so upset about not getting their medicine, and it's kind of sad we've gotten here.
You know, it's funny. I never get anyone throwing something for their cholesterol medicine.
No, but their Adderall, they're going to hurt somebody.
That's right. That's exactly right. And so, yeah, we're going to touch base on that. And, you know, this will be a 2-part series because, you know, we'll actually touch base a lot on ADHD. ADHD truly has now become more of an issue, and we really going to kind of dig into the whys, but we'll touch that on episode 2 of 2023.
Yes.
Yeah. So,
Okay.
all right. Well, Melissa, we'll start with CCM and wearables. So obviously, you know, I wear a Fitbit and you wear a Garmin.
It's a Garmin.
Yeah. And it's everywhere, you know, it's all the rage, you know, nonstop advertising, wear this. Even people who don't have diabetes, they're saying wear this continuous glucose monitor, watch, you know, so you can see what your sugars are doing all the time. What do you think?
Well, I think in some cases, or probably in most cases, when we're talking about wearables, it's all about behavior change. If it's going to motivate your behavior to improve or act differently, whether that's adding more physical activity or changing your diet or any number of lifestyle changes, even these watches monitor our sleep patterns and things like that. If it's truly going to help guide some positive behavior change, then I think they can be great tools. Now, sometimes people can get a little bit, too anxious over what they're seeing and maybe read too much into it. So there can be a downside. But if you're truly wanting to just get some feedback on how things are improving as you make behavior change, I think that's a good use of it.
Yeah, and I totally agree with you. I think from a general population health study, saying continuous glucose monitors in diabetics, it didn't seem to make that big of a difference. But, I agree totally with you. This is going to be probably a person by person thing. Because maybe some people, it didn't help the high risk diabetics because they're high risk for a reason. And, and they already know what their sugar is because they check it on their finger. So adding another layer didn't really help change their behavior a lot. But at the end of the day, the point of wearables is patient behavior changes. So if you wear a smartwatch and it makes you walk more because, and my Fitbit does it, you set your 10,000 steps and you walk and you do find yourself, late at night, you're kind of watching a show and you look at your watch, you're like, oh man, I only have 1,000 steps left. So you kind of stand up in your living room, you start kind of walking around in a circle, looking kind of crazy. But if that's the habit that it will help with, then actually I agree. I think it's helpful. If watching the sugar changes your diet, right? So you start noticing hey, when I eat this, my sugar starts going up. That's a beneficial, feedback. But you're exactly right. I had a patient one time was mowing the grass with their smartwatch. The smartwatch picked up atypical heart rhythm because obviously your wrist is vibrating. Yeah. And they come rushing in there or they go to the ER because they think they have a heart attack. Just to find out that, it's because my heart, then that's the downside, right? People can become a little too neurotic, a little too intense of knowing everything in their body.
Right. Even sleep patterns, people get really kind of hung up on those. They'll come in and report that they're not getting enough time in deep sleep and different things like that. And that may be true, but I also don't know, how accurate it truly is. If it's just, something on your wrist while you're sleeping at night, maybe it's, not reading things that, as well as
exactly
it should.
Yeah. And exactly. And our whole, my approach always in medicine has always been, if we do something, what's the benefit? It's just getting more data to me is not a benefit, right? Just because when you put a sugar monitor on and now your sugar's 300 all the time, but you don't eat any better, to me that didn't, you didn't do anything. Nothing helped, right? But if that truly does help, so I would say if it truly does help change your behavior, improve your behavior, then I think that's something that can be helpful for you. And maybe something to invest in. And that's kind of a way to look at it. We invest money into lots of things, often useless things, but if this is something where we can invest our money in and it actually produces better outcome, then I would say That's a good move for technology.
Yeah, and I think for the glucose monitors, it's important to distinguish that mostly just diabetics need that continuous glucose monitor. You know, there's a lot of push for just anybody and everybody to wear one, and there's not a lot of evidence that that is helpful at all. But for diabetics, if they are working to get their average blood sugars down and they see that when they take a 10-minute walk after a meal, their sugars seem to be better controlled over the next few hours, or if they change up their diet a little bit, they have that kind of instant feedback where they know what they're doing is working, and that can be really helpful for those average blood sugars in a diabetic. But for the average person, we're supposed to have some natural fluctuations in our blood sugar. And some people do get too worried about, oh, well, I ate half a banana and my sugar went up. Well, of course it did. You know, it's supposed to, but they kind of get hung up about that too.
Exactly. So I would say the verdict for wearables is case by case.
Yeah.
So there's not a definite no from our, expertise and you're looking at the data, but it's just something that could be helpful if you realize it's going to change your behavior. And if it's not, investing money in something that doesn't change anything to me is kind of a waste of money.
Yeah.
Right. All right. Melissa, let's move on to number 2, and we're going to touch base on these childhood vaccinations. All right. Now, Melissa, we don't remember polio.
No.
We barely remember chickenpox.
Right.
I had chickenpox.
Me too.
Yeah.
But I think we were like the last. We were like the last generation.
Yeah. And, measles, mumps, rubella, all these other childhood diseases that were really, really eradicated by vaccination. I mean, that is truly a power to society of how mankind really came together. And even, with polio, I'll tell you this. So this was invented by a guy named Dr. Salk, and I think it was University of Pittsburgh. And when he invented, polio is devastating for children. It truly is. These iron lungs, kids lined up. And when he invented this vaccine, he gave it for free. He didn't put a patent on it because to him, this was life-saving this is his gift to humanity, essentially. And I saw the other day, they valued the polio vaccine at like $7.8 billion. Wow. I'm sure his kids are like, Dad,
why do you have to be so nice?
Dang it. But polio, when we came out with the polio vaccine, we went through a double-blinded randomized control trial, even though knowing that, hey, kids were getting pretty sick. It was like 100,000 children. It was a big trial. It was very well done, which kind of made it frustrating that it's 2023. We're not running trials like this. But, he did it. He did it the right way. It works. It eliminated polio. It works. That, I think, when I talk about spillover, COVID, on the other hand, really leaves kids alone. So this is one of the few disease processes where children actually do very, very well. The elderly do not do well. Most diseases hit children and elderly very hard. And so I think when the COVID vaccine came out and there was this big push for mandating that in children that caught it and recovered and were fine, that I think put a really bad taste in parents' mouths, because this is your children, and you just watch them have a runny nose for 2 days and that was it. And you're like, wait, why do I need to inject this into a child? So I understand the spillover, but childhood vaccination, Melissa, is crucial.
Yeah. And they've been around for a long time. They work a lot differently than, the new COVID vaccine technology. So, these vaccines have been around and trusted for a long time. And like you said, he wasn't trying to make any money off of a polio vaccine. He was truly trying to help people. And I think that's where the whole COVID pandemic and vaccination really divided people, regarding any type of vaccination. So it's not all about the money, in all cases. And these childhood vaccines are truly there to help your kids.
Yeah, exactly. And the last thing we do not want to see a measles outbreak. So, to put it in perspective, Omicron, which is what most people caught last winter, that contagious level is measles. Measles' contagious level is that level of Omicron, except outcome for measles in children is significantly worse, right? And so if you looked at that level of contagiousness that we had last winter, but just made it way worse for children. It is a no-brainer that we don't want that thing coming back, And so, I would say, looking at this news story, we understand from the really bad rollout with COVID vaccination and the bad taste that mandates left in people's mouth for COVID vaccination. For me, I don't really think mandating it makes any difference now in 2023. But for children's vaccination, going to school, these devastating children's diseases, I think definitely parents need to take into serious consideration the benefit of that. And really in that, not paying attention to a lot of really bad observational study or these anecdotal, this shot made, this happened to one of my friends. And, those studies are really pretty useless in the grand scheme of public health.
Yeah.
Yeah.
Agree.
So to wrap that up, get your childhood vaccinations.
That's right.
Because that actually has really good data and benefit. All right, Melissa, moving along. Mental health and burnout.
Yeah.
Bad.
Yeah.
I think we probably should have been able to predict that this was going to be bad. We're human beings. We like interaction. In fact, my love language is physical touch. So if you isolate me and say, don't touch anybody, that would be really bad. But we didn't. We kept, and so obviously mental health right now in our population is really, really poor. And that didn't just happen to teenagers. People oh, teenagers have mental health. It happened to physicians and clinicians and nurses and, it was really bad.
Right. Yeah. I think no matter what setting you were in the past couple of years, just that social isolation was a big part of it. And then when we look at clinician burnout specifically, we were already burnt out before a pandemic. There's a lot of problems in healthcare that causes clinician burnout. And then we throw a pandemic on top of it. And we see a lot of the workforce leaving. And I think we see that a lot in other industries too. You can't find people to work in a lot of different industries, but healthcare was hit really hard. And like we mentioned a few minutes ago, about 10% of physicians, we actually lost physicians in the past, I think that was 3 years, from 2019 to 2022. So that doesn't count other support staff and nurses and everybody.
Yeah. And obviously you talk about, even right now this winter, you talk about hospitals being full. It's not full because we don't have room. We've got rooms. It's full because we don't have staff.
Right.
And a lot of the staff aren't coming back.
Right.
And the reason they're not coming back is truly burnout and mental health, which again, you talk about, forget pneumonias and hospital. We're talking just about taking care of heart attacks and strokes and how we've heard over and over, sometimes we don't have enough people to staff our cardiac units to take care of people who have heart attacks. And if you look at our population health, we're not we're not running from heart attacks. Those things are going to come unless we start trying to do something different. But that, it's a problem.
Yeah. I think that work volume, we hear all the time that nurses working in the hospital have way more patient load than they really should have to keep things safe and efficient for the patients. We see the same thing in a clinical or outpatient setting where, we are seeing, not necessarily you and I, but just clinicians in general are seeing way more people or volume than they can handle safely and efficiently. And so maybe what was supposed to be a 15-minute visit or could have been handled a lot better in 15 minutes, they're really kind of flying in and out of that room in 5 minutes. Things are getting missed. Patients don't feel heard. And it's a vicious cycle.
Yeah, exactly. And I think that actually is what burns out people more than people. I feel like me talking to patients all day long, that's not what burns me out.
No, it's not. It's not a patient problem. It's the structure of how healthcare is delivered.
I totally agree. Yeah, it's I feel like when physicians or clinicians or nurse practitioners, we go into healthcare with the view that we're here to help people, right? Sitting at bedside with a patient who is passing away is what we come here for. This is why we come, and having all the resources and autonomy to feel like we can take care of this patient the way we feel like they need to be taken care of, that's very rewarding. That's why we choose a field. That's why that's why physicians and people donate their time to go to foreign countries to take care of people that are underserved. And that is rewarding. That's what we do it. But when we feel like there's barriers there that block us from being able to do that, and by barriers, I mean, look, there are things you have to do that you don't want to do. That's life, right? But when you have a lot of barriers to block and you don't even know why these barriers are here, I think that's what kind of contributes to the burnout.
Right. And a lot of healthcare structure isn't necessarily set up for the benefit of the patient, and certainly not the benefit of the clinician. But in that kind of disconnect, the people that are kind of stuck in the middle get burnt out.
Yeah. Ooh, real talk here, Melissa.
I know. This has been pretty hard.
That's right. We're
getting information here.
That's right. We're getting pretty serious. And so I would say, I always like to offer solutions. And one way to really combat burnout really is to, I tell people, let the team work. Clinicians are trained to do this, administrators are trained to do that. Dietitians are trained, and PharmDs, everybody's trained to do a job in their certain way. And sometimes you just need to step back and let them figure out what's the best for their patient population. And sure, that might affect, your profitability. It might affect your bottom line. You might not, it might be the difference between somebody profiting, $100 million versus somebody who profits $1 million. But in the end, healthcare really it shouldn't be in a profit-making business. It should really be in a patient care business. And as long as that, offering good care equals better pay, that everyone's rowing in the same direction, that actually will solve a lot of burnout. But if it's rowing in the opposite direction, where to get better patient care, we're pulling in two different directions, then I think that's something that actually needs to be honestly addressed. And sometimes it can't be addressed. It needs to be addressed almost in Congress, something bigger than just what we feel in a clinic.
No, for sure. Yeah. And these are the issues that have been going on for years, even since you and I finished school, many years ago. So we're just still trucking along.
Well, I realized the other day, I was like, man, I've been out of residency for 10 years. Lord have mercy. I was like, a decade.
Yeah.
I feel it in my back and my knees now. Yeah, those all-nighters, it used to be not a problem. Now I'm just getting old.
Yeah.
So I would say, wrapping that up, this will become an issue for all patients. When people are listening to this podcast, a lot of them are patients. This will be something that we all need to maybe put our minds together and address, and then, maybe also, show more, mercy and grace to one another. Because, we are learning, and even here, this is what we're trying to learn here in this clinic. How do we get us back to what we enjoy, which is taking care of patients, getting really good outcomes. Everybody wins at the end. Patients healthier, we're happier, and we are being paid to keep people healthy. That's the whole concept in the end. If we can get there, I think we can really address this big problem.
Yeah, definitely.
All right, Melissa, we are going to our final thing.
Yes.
And then we will focus in on ADHD.
Okay.
Drug shortages.
Yeah.
Yeah, specifically ADHD medication, blood pressure medication, Ozempic, we talked about that. This is becoming an issue, a big issue. And again, this is probably beyond our scope. Like, I can't go tell a manufacturer to make more Adderall.
Right. But, and I think, part of it is what's trending at the moment. With Ozempic, we saw that, like we talked about, probably started on TikTok somewhere. Somebody saw it and it just spreads like wildfire in today's, social media and everything. Things just spread really quickly, and there's other ways to go about getting certain medications now. We touched briefly on telemedicine. So instead of having to take time out of your day to go make a doctor's appointment and drive to the doctor and sit and wait and all that, you can really on your own time at your desk at work, do a telehealth visit with a provider and get prescribed any of these medications. And so as more and more prescriptions are going out, there ends up being a shortage. And so that's part of the problem, I think.
Yeah, well, I guess this is actually probably a good time for us to wrap it up, Melissa. We actually covered a lot today. Like we told our listeners before, this will actually be a 2-part series. So next week, we'll be really wrapping up this matter of ADHD and what we can do with it, with medication and without medication, maybe even going over some of our testing. But for the sake of time, Melissa, I think we'll wrap it up. Again, thanks so much for your time.